So how do you help engage clients in outpatient services? Research has shown that this population in particular, the co-occurring population, has a really difficult time with this therapeutic alliance, with this engagement process in treatment. So they have a particularly difficult time committing to and maintaining treatment in comparison with a population that only has substance use issues and not mental health issues as well. So having this model of continuous outreach, having individuals out there, finding people, connecting with people and encouraging them to receive services can be really helpful. And also strategies particularly aimed at engagement. Often these can be within the realm of motivational interviewing strategies, helping someone connect with you even if they're resistant or they're not at a stage of change where they're willing to participate in treatment. And it's important to note for those not familiar with motivational interviewing that you actually can connect with people quite successfully, even if you would prefer they be at a different stage than they actually are. I mean, just because someone isn't willing to participate in a full-blown treatment doesn't mean that they can't connect and engage. It just might take a little bit more time. Also, and you'll see this thread come up a lot in the upcoming modules, is this concept that co-occurring individuals with co-occurring disorders have these numerous other issues going on in their lives, like homelessness and criminal justice charges, and they might be at risk of losing their children for Child Protective Services involvement. So trying to help them deal with some of these immediate life problems can be an important part of connecting and treating them. Advocacy, how do you as a professional advocate for and work for the individuals that we serve? And also close monitoring of individuals' needs, so that you can make sure that you're right there with that person, and that whatever they need in that day or that moment, that you're going to attend to that and be ready to respond. Those are all elements of how you engage with someone. So how do you improve adherence, to treatment for clients with co-occurring disorders in outpatient settings? I don't know about you, but I get a text reminder and a telephone reminder from my dentist, reminding me it's time to come in. Sometimes it's the only thing between me not showing and showing, so it's pretty important to me. Do you as an organization provide reminders for people that it's time to come in? Reinforcement for attendance, we talked about this, having snack, lunch, reimburse them for transportation might be helpful. We talked about it in the context of client involvement in your committees and in your input, but it's also important for attendance as well if you can. And increase the frequency and intensity of outpatient services offered when it's required. So if someone has a crisis or an immediate need that comes up, how well are you, or how capable are you as an organization to step up to meet that intensity? How long does the person have to wait in your waiting room? Now, I don't know about you, but in many of the places I've worked the past several years, it really tends to be clinician dependent. Some clinicians are like right there, very timely in the waiting room picking up their next client. Others tend to be a little bit more relaxed in their approach. So being aware as an organization of whether or not there are some wrinkles in getting people into those sessions is important. Also, as we alluded to earlier with having trained staff, having co-occurring specific outpatient treatment. What groups do you have that are co-occurring specific, and do you have clinicians who are trained that way? Do you have case managers who can do outreach and home visits? Sometimes being able to meet that person in their home is the best way to get them to reach them. And how do you coordinate treatment with other systems of care for the client? And those systems of care can include The schools, if you're working with an adolescent, it can include the criminal justice system, the United Way organizations in the communities, or senior services, or any other types of human service organizations that someone might be engaged with. It could also be, the church, if individuals are actively participating in church. And then discharge planning. How do you help the person maintain gains achieved through outpatient care? And you'll see this theme come up a couple of times. Discharge planning doesn't occur on the last day of treatment, right? So it isn't the case that, okay, it's your last day, let's sit down and do discharge planning and let me write out what you're supposed to do. Discharge planning starts from day one. So the day the person's admitted into the program, you're thinking as an organization, how do I prepare this person for their next transition? And it's part of their treatment process, figuring out what those needs may be. Because some things may take a while to pull together for them. If they're homeless, you certainly don't want to wait until the last day to try to figure out where they're going to go. So some of those processes take a little bit of time, and you want to be thinking about it as soon as you can. Relapse prevention groups. What groups do you have that will help the person start recognizing and planning for relapse prevention when they're not in the program anymore? Individual counseling and therapy, mental health services if they need them, and intensive case management. I'm not going to talk about that too much because there's an upcoming module that will talk a lot about intensive case management. Continuing care and relapse prevention. So after the person is discharged from the program, you should have some mechanism of post-treatment monitoring. How do you check in with someone after they leave and make sure that they're continuing to do well? Now, part of discharge planning, and this would be part of relapse prevention, I'm assuming, in your organization, is trying to help the person recognize when they're in trouble and when they might need to come back. So post-treatment monitoring, you might be reminding them of that. So if it sounds like you might be struggling, or here's some other issues. Here are some symptoms that you may want to be looking for that might result in you calling us back for services. Treatment if they need it, and then encourage to return to treatment if they need to for either disorder. So standard outpatient staffing in outpatient programs include both mental health specialists, psychiatric consultation, and off-site psychopharmacologic consultation. So how does the person get consultation? How do you get consultation, even if it's someone not on your staff? What I've also found is that pharmacists can be incredibly helpful as well. If you have a question about medication, often they might be, in some ways more aware than primary care physicians of some of the drug interactions and issues in both the substance abuse, primary care, and behavioral health side. So don't forget about your pharmacists as well. And the pharmacists that I've worked with, they also know where their limits are and where they wouldn't want to answer a question, but they're generally quite knowledgeable. So training should include several elements. One should be recognizing and understanding symptoms of mental disorders. This is, directly from the tip, but I would add here as well is physical health disorders. In co-occurring disorders in the tip, it tends to be pretty narrowly defined as mental health issues and substance abuse issues. But you could be assessing someone for substance abuse and mental health, and you could come up with symptoms like fatigue, or poor concentration, or insomnia. And you might be thinking, okay, let's see, sounds kind of like depression, might be, alcohol use. I mean, you're trying to differentially diagnose various things. It could also be diabetes, so making sure that you have at least a general understanding of some of the symptoms in the diagnostic categories you're diagnosing, and which may also be mimicking physical health conditions. Now, obviously, you're not going to be diagnosing diabetes. That's not what I'm saying. But if you're aware of some of those symptoms that overlap in the physical health side, then as a general rule, I ask people, so when was the last time you had a physical? You know, and has it been a long time, and did they do blood work? And is your doctor worried about any physical health conditions? And if they say, I haven't seen my doctor in several years and I haven't had lab work as long as I can remember, then I would be encouraging them to get a checkup, to see their doctor, because their doctor can help rule out some other conditions that you couldn't diagnose. Understand the relationships between mental symptoms, drugs of choice, and treatment history. You know, how do they roll out in the person's life? And there are many reasons that this is important. You know, when you get to diagnosing, if you're someone who does diagnose, you'll want to be trying to determine, is this substance-induced? You know, is it a mental condition that is directly related to the person's substance use, or is it a standalone issue? Is it a true co-occurring disorder? If someone comes in and they're expressing some symptoms, and you've ruled out intoxication or withdrawal, and the person reports that they had these symptoms starting at the age of 15 and they started drinking at 18, then you can be pretty sure that it's probably a mental health condition and not due to substance use. So that's why it's important to understand how those roll out in the person's life. Individualizing and modifying approaches to meet the needs of specific clients and achieving treatment goals. So make sure that you're being client-centered and that you're involving the client in what treatment goals they have, and that you're adjusting. You know, I've had numerous instances in the past where, you know, someone gets really excited about one evidence-based practice and they really dig in, and that's all they do. And then all of a sudden it tends to look like, if all you have is a hammer, everything looks like a nail, you know? So if someone gets really good at one evidence-based practice and that evidence-based practice happens to be for one specific disorder, then everyone in their caseload has that disorder. You know, so this is just a reminder that you make sure that you're adjusting your approach that's evidence-based for what that person is experiencing. Something like CBT tends to be a little bit more of a broad treatment that covers a lot of different disorders, but you want to make sure you're matching the treatment to the specific issues of your client. Also, access services from multiple systems and work with integrated treatment plans. You know, so you want to make sure that you that all of the treatment types that are in place for your client are working together. You want to have training in the nature of addiction and mental disability and the interactive effects of conditions on the the person and their outcomes, and also staff burnout. I would also add here, this is another area that tends to have received much more awareness in the past several years, is the concept of trauma in staff. You know, that if you have staff that are working with really difficult cases, make sure that they have training and being aware of how working with people who have had trauma might cause some trauma symptoms in themselves.